Good afternoon, everybody. A very warm welcome to this afternoon's neuro-ophthalmology session. The title is, What Happens After You've Diagnosed? And in this session, we have an ophthalmologist paired up with a specialist from another specialty, such as neurology or immunology, because we often wonder what happens after we've diagnosed optic neuritis or giant cell arteritis. At which point do we hang on and at which point we move on? So we've got a very exciting program and a bit of housekeeping. So firstly, I would like to thank the Congress. I would like to thank my co-chair, Claire, and Professor Danish Meyer for organizing this session. For the questions and answers, we encourage you to please use the app to ask your questions, and we'll have each pair of the specialists up here at the end of each topic. There is a microphone at the front if you want to, but we'll be testing your depth perception coming down the steps. Okay. So without further ado, I would like to firstly introduce Professor Lynn Gordon to give us the ophthalmology perspective of optic neuritis. Thank you very much, Lynn.
Thank you so much for your kind introduction. And it's a real pleasure to be here in Brisbane and in Australia. I have no financial disclosures relevant to this talk, and really what I want to try to convey is to understand the ophthalmic approach to the patient who presents with optic neuritis, and to talk about some of the critical testing, laboratory as well as radiology, that we think about for all patients with a new onset of optic neuritis. I always like to start with a case. So this is a patient who presents with left eye vision loss and pain, 45-year-old male with a 1-week history of worsening blurry vision in the left eye. He had pain in the supromedial left orbit, worse with eye movement, which is quite important, and he denied systemic symptoms that were neurologic, so denied weakness, numbness, ataxia, tingling, also difficulty breathing, trouble with bowel or bladder, and denied any recent flu-like illness. When we looked at him, his visual acuity in that affected eye was 2200, and it did not improve with pinhole or refraction. On Ishihara color plates, the color vision was down. He had a relative afferent pupillary defect, and he had full range of motion, but described pain worse with adduction. Looking at his slit lamp, it was otherwise normal, and formal visual fields were full in the right eye, but diffuse abnormality in the left eye involving fixation, which you'd expect considering the decreased visual acuity. Now, when you looked at the back of the eyes, you see sort of optic nerves that don't look particularly bad. And so when we talk about what we consider to be a typical demyelinating type of optic neuritis presentation, we think of it being subacute, taking days to weeks of vision loss. Typically, at least in the United States, these patients are young, mean age of 32, more often female than male, but we do see it in males. Pain is a hallmark of that typical demyelinating type of optic neuritis, present in 92% of patients. So you can have a male who doesn't have pain on eye movement, who does have a demyelinating type of optic neuritis, but it's unusual. The pain can actually precede vision loss, and it can last for days, but it doesn't correlate with a bad outcome visually or clinical course. Visual function can range from 20/20 to no light perception, but if it's no light perception, you have to worry it's not typical demyelinating optic neuritis. That would be really unusual, but 20% do have worse vision than 2200. About 90% of these patients will recover to near normal Snellen acuity, but then we need to think also about contrast acuity and retinal nerve fiber layer as well. The fundus looks normal in about 2/3 of patients, and optic disc edema in about 1/3. You should not see optic atrophy in the beginning with a patient with a demyelinating optic neuritis who has not had a prior event. Now, in the US, we do MRI brain and orbit in all patients who present with what we feel is even a typical demyelinating type of optic neuritis. And we know from the optic neuritis treatment trial, which now was done decades ago, but really taught us so much about this disease, was that the 5-year risk of developing multiple sclerosis was even 16% in patients with a normal MRI, but up to 50% in patients with a few lesions. And then it increases over time. So even with a single lesion at the time of onset of that typical optic neuritis, the 15-year risk of disease is about 3/4 for multiple sclerosis. And just some typical photos that we would see of the MRIs with someone with a demyelinating type of optic neuritis associated with multiple sclerosis. However, we need to remember that the ONTT enrolled only patients with unilateral disease. The average age was around 32, which I already told you, and the majority were female, and the vast majority were identified as white or Caucasian. And so all bets are off when you're dealing with patient populations that differ from the population that was seen in this treatment trial. So when we think about this typical optic neuritis, treatment has a short-term benefit in rate of recovery, but not in final Snellen acuity. But note, contrast sensitivity, although people have now reported on it from the trial, was not a primary outcome. And of course, we didn't have OCT then, so we didn't really have retinal nerve fiber layer or notice about retinal ganglion cells. And what we did learn from that trial, that oral prednisone was contraindicated. And in that trial, it was associated with a higher recurrence of optic neuritis. But what we do know is that immune modulation in multiple sclerosis is really important. And there's multiple medications. They all have extensive side effects, and I never prescribe them because I work with the neurologist who is expert in multiple sclerosis and expert in using these medications. But we have to back up for a brief moment and say, well, what if it's not typical? And I'm not going to step on the toes too much of some of the next presenters, but I'd be remiss in just saying, well, this is typical optic neuritis, so let's move on. So when we think about atypical optic neuritis, we think about simultaneous bilateral vision loss. That's very rare in demyelinating or MS-associated optic neuritis. No light perception, which I already told you about, you can have it, but it's unusual. If it's progressive after 2 or more weeks, they continue to lose vision, something is wrong with your diagnosis. If there's no recovery after 3 weeks, you have to rethink that you made the wrong diagnosis. And if there's worsening vision after the steroids are stopped, again, rethink your diagnostic strategy. If there's no pain or severe pain or persistent pain, you need to think about other diagnoses. And then when you look in the back of the eye, if they've had optic atrophy without a prior history of optic neuritis, one needs to think. And I remember clearly a patient sent to me with optic neuritis, and they actually had a glioma. And the reason why we made that diagnosis or thought about it initially was this optic atrophy that this patient had. You know, with a 1-week history of disease, it just doesn't fit. So when it doesn't fit, you need to do more diagnostic testing. So if you look in the back of the eye, there's severe disc hemorrhage, edema with a macular star, aqueous or vitreous cell. Again, you need to think, what else could this be? And the photo down here just shows a patient who has some optic atrophy in one eye, and then you need to think twice about your diagnosis. Other times that we think about atypical are age, younger than 12 or older than 50, systemic history of diseases, whether it's cancer, connective tissue, autoimmune, immunosuppression. You need to think carefully about what you're doing. Again, if they have systemic symptoms, you need to worry about it. And then if you have MRI findings that are just unusual for that typical demyelinating optic neuritis that we often see with MS. There's a long differential, but we always need to differentiate nowadays whether the patient has NMO spectrum disease or MOG or MOGAD disease. And I also would be remiss not talking about children, and I don't see children, but many of my colleagues do see children with optic neuritis, and so you need to understand that this is a different disease in many cases. So it's bilateral in up to 72% of children younger than 10. Optic disc edema is very common. Pain is not as frequent. Visual outcomes are good, but not quite as good as those patients with typical optic neuritis, and the risk of multiple sclerosis is not well defined, but it's a little bit less than it is in an older age presentation or with certain MRI abnormalities. Optic neuritis is the presenting symptom in 10 to 20% of patients with pediatric MS, and the average age is around 13. It does have a female to male predilection, but not quite as much as in adults, and relapsing remitting form is most common. You need to distinguish from ADEM, which is often associated with MOG. I'm not going to go into this in very much detail, but what's important is that this is seen in young patients. Males are more common than females. Anti-MOG antibodies are common. You need to make that diagnosis, and you need to make the diagnosis of neuromyelitis optica. Even though that's pretty unusual in the pediatric age, it can happen. So what do we need to do in all or almost all patients with their first episode of optic neuritis? We need to do brain and orbit MRI with and without contrast, sometimes spine as well, especially if you're thinking about NMO or MOGAD. Low threshold for testing aquaporin 4 and MOG. Start high-dose intravenous methylprednisolone. Consider plasma exchange, which you're going to hear about in subsequent lectures. And we're really focused on this because long-term treatment and prognosis and systemic prognosis is different for the typical or the atypical optic neuritis. So treatment decisions need to be made along with our colleagues that are trained in demyelinating and autoimmune diseases. And disease-modifying therapy is critically important. So I'm going to stop there, and thank you so very much for the invitation.
Professor Gordon, we'll get you to come and join us up on the stage here while we invite our next speaker of this session, who's Professor Andrew Lee, who's going to give us the neurology perspective of optic neuritis, and then we'll have questions for the pair of them.
Afternoon, ladies and gentlemen, and I'd like to thank the organising committee of Professors Fraser, Dennis-Meyer and Chen for inviting me. My role is to outline what happens after you've diagnosed optic neuritis and pass this on to the neurologist. Now, I just want a show of hands in the audience. How easy is it for you to get in to see a neurologist for your patients? Yeah, it's a bit of a laugh, I know. Look, we'd love to see your patients really, really quickly, but there's a workforce shortage. Hopefully you don't have to be married to your neurologist to get a consult. What I want to sort of try to outline is that if you send a referral and you say, I've got a patient with MS, I've done the MRI brain and spinal cord and I'm considering a lumbar puncture, we'll probably say, wow, this is amazing. We want to go and get this patient in as quickly as possible, no matter what the results is, because somebody has actually taken the time and effort to try and make our lives a little bit less hectic. And so I do apologise on behalf of our neurology colleagues when we can't see the patient, but it's actually more a government issue than anything else. So what I'm going to talk about is four main things: the pathogenesis of MS, how that relates to the diagnosis in terms of the clinical picture, why am I emphasising the CSF oligoclonal ban, and what could be an appropriate follow-up for the clinical isolated syndrome with no lesions on MRI. So let's talk first about the pathogenesis of MS. This is classically a polygenic pathogenesis where you've got a predisposition of an individual with some sort of genetic abnormality as well as an environmental component. And then there is a whole bunch of immune events that occur resulting in demyelination, and it is that demyelination which results in a reduction of the neuronal transmission, resulting in various clinical syndromes. And at the same time, we can also see the demyelination on MRI scanning, where you have the typical T2 and T2 flare-weighted images seen there. And often one of the problems when we do get the MRI is that you may have a non-specific report where the radiologist suggests that these T2 images could reflect any number of very scary neurological conditions. Sometimes it's quite hard to then work out what needs to be passed on and what doesn't. So the main issue when we're dealing with MS is what do we do with the imaging after seeing a clinically isolated syndrome. One really needs to have an MRI brain, and at the same time while we're doing the MRI brain, an MRI of the spinal cord, gadolinium is important because it gives us an idea of dissemination in time, and then followed that in turn by lumbar puncture with CSF oligoclonal bands. This comes from the revised McDonald criteria for MS published in 2017. And as I mentioned in the pathogenesis, what we need to look at is inflammation, not just disseminated in geographical space, but also in time as well. We can see dissemination in geographical space in terms of the clinical picture where we have lesions involving various parts of the neuraxis. For example, involvement of the corticospinal and spinothalamic tracts within the cerebrum will result in weakness, brainstem nucleus dysfunction with diplopia, ataxia, a cord syndrome with paraparesis, and of course optic nerve involvement. When we look at dissemination in space, we can see these lesions, which are often periventricular within the brain and the corpus callosum. There can be also juxtacortical lesions as well, and also lesions which enhance on gadolinium. And gadolinium-enhancing lesions are important for two reasons. One, it gives us an idea of the dissemination in time, but also it gives us an idea of what lesions are active versus what is not. And the degree of disease activity may change how you deploy an immune modulator. Now, the MS diagnosis following optic neuritis, if you've got a typical MRI with typical lesions on gadolinium and optic neuritis, you can probably secure the diagnosis based upon dissemination in time and space. But the question then arises, which is more complex, is that if you've got an optic neuritis with MRI lesions but no GAD enhancement, what do you do in terms of dissemination in time? And the way to determine that is by using a lumbar puncture. Now, I'm not suggesting that you as ophthalmologists should do lumbar punctures. That would be as equal as you saying to me, can you use a slit lamp? I know I have difficulty turning one on because it's hard to find when the on button is. And the CSF should be performed really of the clinical and the MRI pictures, not classical, for the diagnosis, especially when we're considering immune modulator therapy. If there is a progressive course following a clinically isolated syndrome, and as Professor Gordon has already said, in populations where MS is not useful, for example, in children, older populations, non-Caucasians, or say bilateral optic neuritis. Why are the oligoclonal bands so important? Well, in a way they predict what will happen into the future. So here is a cohort study of clinically isolated syndromes. They divided it into those individuals who had a clinical picture of worsening MS, which is according to the Barkov criteria, in those individuals who had MRIs, and in those individuals with oligoclonal bands. And from there, they worked up in almost a 2x3 factorial design follow-up as to what is the prognosis. And what we can see here is that as there are more clinical features of MS, as there are more MRI lesions, and also with oligoclonal bands, that the risk of MS increases. But when you stratify it just with the effect of the oligoclonal bands from the multivariate analysis, you can see clearly here that the risk of developing MS into the future is quite high. The presence of oligoclonal bands can therefore be used as a substitute marker of dissemination in time. And we need to consider this particularly if there were ocular manifestations of other autoimmune conditions, if you have the negative MRI with oligoclonal bands, in appropriate populations with the presence of infections, as well as paraneoplastic causes. The question then is, okay, if you've now got a truly clinically isolated syndrome, how long should you follow up the optic neuritis? Now, at this point in time, you hope that the neurologist has come to your aid, okay, because the usual 12-month waiting list has elapsed. I kid you not, it's not I would like to see them earlier, but you get a lot of syncope as well referred to your clinic, which could be MS. And it depends on the total number of lesions on MRI. As Professor Gordon has stated, that in the ONTT study, if you had nothing on MRI, the risk of developing MS could be up to 22%. If you have more than 5 lesions on the MRI, your 10-year risk is about 70% or so. It's important to realise that MS is a treatable disease. There are a large number of treatments. You can see here at the top the more effective monoclonal antibodies. which are highly efficacious, right down to the early injectables. They do have side effects, but in general the side effects aren't too bad, but usually neurologists do initiate these. So in conclusion, to establish a diagnosis of MS, what I need to do is to do an MRI brain and spinal cord with gadolinium and go ahead with CSF oligoclonal bands. The risk of developing MS can vary between 20 to 70% depending upon the number of lesions as well as the presence of oligoclonal bands, and that modern immune therapy really does have the ability to place MS into remission, and hence one should follow up the clinically isolated syndrome as long as possible. I normally follow them up over about a 10-year period, and if I don't see any further events, then I'll say, look, chances are that you're not going to develop MS into the future. Thank you.
Thank you very much. So we've got one question from the audience, and I'll address it to Professor Gordon and then Dr. Lee. Do you treat everyone with typical optic neuritis?
So my thinking has changed over the years about this. If you had asked me when I was a resident prior to ONTT, I would have been treating them with oral steroids. Then we went after the ONTT to either treating with IV or not, and then there are some groups that are treating with very high dose oral as well, but I have not done that. I offer it to all patients. Even with typical, what I think is early demyelinating optic neuritis, because we do know that it hastens recovery. Now, there is risk when using high-dose steroids, even for short term, and so you need to always judge the risk-benefit for each individual patient. But for example, one of my patients many, many years ago now was a 55-year-old male who had a bit of decreased vision in one eye for another reason. So he got optic neuritis in his best eye, and he was an executive in the entertainment industry and had to read scripts all the time. He needed his vision yesterday. So that would be a patient that I would always treat. So I think that it means discussing with patients risk and benefit, but I tend to treat.
Absolutely. Yeah.
What do you think?
Oh, I find that if I've got a patient with typical MS, I would treat purely because the immune modulators do alter the natural history. Even though in those individuals where the symptoms may appear to be benign, like say a sensory disturbance in the hand or something of that nature, when you look at the MRI, you can certainly see the evidence of demyelination. And we also know that there can be axonal loss of brain volume that you're not going to pick up on basic neuro testing, but you may pick that up on more neuropsychological testing.
So does that mean that 12-month wait that we've got to get them into you and start these disease-modifying agents is potentially a negative impact on the patient's outcome?
Yes. But if you send them to Adelaide, I'll guarantee I'll try and get them seen quicker.
I just have one more quick question, which I think will have to be the last question for this session. The ONTT was done on old-fashioned MRI scans a long time ago. Does that one lesion risk still hold true, given that we've now got 3 Tesla magnets and more sensitivity to smaller lesions?
Good question.
I don't know the answer to that. Dr. Lee?
Good question. I think maybe not so much, purely because if you've got higher Tesla MR, finer slice thickness, you can actually see smaller lesions. There's also other things you can also do, like say magnetic transference imaging as well, which will then demonstrate demyelination in grey matter. So I think there is a continuum, and you just wonder whether you just put them on immune modulators on almost everybody. But then again, if you've got an atypical syndrome, then we've got problems. But I'd be interested what.
Yeah, and then you would treat them differently, right? And much more aggressively. But I think, I think as we evolve with testing, we have lots of different modalities of testing as well. And starting to use all of the different types of testing we can, neuroimaging, looking at oligoclonal bands, looking in the eye, looking at retinal nerve layer, looking at retinal ganglion cell layer. All of these different modalities together can help us do the best for the patients, because that's really what we all want to do.
Thank you very, very much. Next we have the wonderful Professor Helen Danish-Meyer, and she's going to enlighten us about neuromyelitis optica. And she'll be paired with Professor Simon Broadley here from Griffith University, and he's actually the person who has done the neuromyelitis optica Australia-New Zealand study. Thank you very much, Helen.
Thanks, Professor Chen, and who do we have here? Professor Fraser, for organizing this conference and also bringing together neurologists and neuro-ophthalmologists together. It's an exciting platform to share ideas, and I've already learned so much listening to our two previous speakers. And Professor Gordon set the stage perfectly for the next two cases that I'm going to talk about, the two conditions, MOG and NMO, because as she mentioned, you really can't talk about optic neuritis and not talk about these conditions now. So this is just to set the landscape of what she has mentioned. So as Professor Gordon said, things have changed in the last 20 years so much, so we have shifted. So, the typical optic neuritis was investigated with MRIs, treated with steroids, and then follow up for 3 months to have considered recovery. That was our traditional paradigm. And then we had this basket of atypical cases, and they were infective, inflammatory, neoplastic, and then something we called cryon, which was basically, should have been, I have no idea what's going on, but it keeps coming back. And that was chronic relapsing inflammatory optic neuropathy, which was an unknown cause, but it did respond to steroids initially. And that's where these two conditions that we're talking about now, NMO and MOG, come in, because they have kind of opened up, taken some of those cryon cases and now put them into their own baskets. And neuromyelitis optica was initially diagnosed in 1894. And I remember when I went through med school, which wasn't 1894, but it was last millennia. At that stage, NMO was a condition where you said it was a bilateral case of optic neuritis, it happened in kids, and it tended to be a one-off episode, and maybe it was related to MS or not. But that was really all we thought about in those who we were thinking about for those conditions. So it was a monophasic condition in children, and it was but now we know that it's actually distinct from MS. It's an inflammatory condition in its own right. It's relapsing, and it can present similar to MS, but also very different. And that's where I'd like to spend my time discussing the difference. And I'll leave most of the neurology to Dr. Broadley, who will be coming after me. So we better understood this condition when we identified the antibody. And that has helped us a lot in kind of identifying NMO. But we still have NMO, negative NMO. And I know that when I say that to the med students, they kind of look at me and say, and I said, yes, it's NMO, negative NMO. And maybe Dr. Broadley can talk about that a bit more in detail. But the NMO is distinct from MS in that it's an astrocytopathy. So it's actually a process that involves the astrocytes, as opposed to the mechanism that we heard earlier in MS. So, and the astrocytes have these aquaporin channels, and they're predominantly located on the optic nerve and spinal cord. And that's why these patients tend to get optic neuritis and transverse myelitis predominantly. And so the pathology is different in these two conditions. There's a range of other neurological conditions, and I will leave Dr. Broadley to discuss the importance of those. But the importance that I'm mentioning it here is when you're taking a history in patients with optic neuritis, you do need to ask about these other things. You need to ask about intractable hiccups. You need to ask about bowel and bladder problems. You need to ask about narcolepsy in children, whether they've had seizures and other conditions, because it will help lead you to the direction in these atypical cases that Dr. Gordon was talking about. So NMO tends to occur slightly more, 90% aquaporin positive antibodies are in females. Age is not that useful and does overlap with MS quite significantly, but they do tend to have underlying autoimmune conditions. So ask about SLE and Sjogren's, but any other underlying autoimmune conditions may be helpful. But it can be indistinguishable from the typical optic neuritis, and there'll be some clues in the optic neuritis difference between the two that I'll discuss in a moment. But the most important point is they have a very different course. And they need a very different treatment paradigm, and it's much more aggressive. As I always say, this is the one time where you want to tell the patient, the good news is you have MS. Because NMO is worse than that. So that's what you have to remember. So then we had typical optic neuritis, and then we had neuromyelitis optica. We had NMO positive conditions and NMO negative conditions. And then we decided that what else is next after that? And then there was still the cryon basket, which was getting a little bit smaller. Then there were these case reports that reported bilateral optic neuritis in children, and some of these cases, they had a specific appearance of their MRI, and some of these cases, if you went on to retest them years later, actually fit into another basket of myelin oligodendrocyte glycoprotein, MOG. So we've got MOG and we've got NMO, and these are both two autoantibodies that now you should be testing in every patient who has optic neuritis. So this is an excellent debate, and Claire, I always refer to it because Claire's done a fantastic job in asking, and they debated whether MOG and NMO should be combined into one family or whether they were actually unique. And so you can see that our evolution and our thinking has really been emerging and changing as we've started to understand the progress of these conditions. But now we actually think that MOG is probably a bona fide condition independent of NMO. It probably has a different underlying pathology, which I won't go into too much detail, but the treatments are probably different as well, and the clinical course is different. So you need to consider both, and you need to treat both differently. So I'm going to spend the last few minutes on this table because I think this provides a good summary of the ocular features differentiating the three. We've got MS or optic neuritis in one column, aquaporin 4 in one, and MOG in the other. So just to highlight the difference between the two, you can see that the ages overlap significantly, either 20 to 40-year-olds. So there is a bit of a sex predilection between with MS and aquaporin 4 tend to occur more common in females. MOG, so not much so difference. But another important thing is ethnicity, and I think this is really relevant. If you have a patient who's a non-Caucasian, think about these atypical cases in particular. Now, they occur in Caucasians. I had a 65-year-old woman who had optic neuritis, turned out to be MOG. I wouldn't have put my money on, I would have bet that it wasn't MOG, but there you go. So it can happen in Caucasians, but if they're not Caucasian, do think more of NMO. And their clinical features are slightly different. So bilateral visual loss, do not put that down as typical anymore. You really need to consider that separately and consider more MOG NMO. And I think if they've, as Dr. Gordon mentioned, if you've treated them with steroids and they relapse when you stop it, stop and think, this is not right. I need to reconsider that differently. And visual recovery. If you're treating them with steroids and they're not getting better, you have to stop and think, this isn't typical optic neuritis, which usually gets better. MOG, on the other hand, tends to respond often very rapidly. You're putting in the infusion and they're getting better. So, but if they're not behaving typically, think, is there something else going on? And the reason it's important to diagnose this early, which I hope that Professor Broadley will talk about, is that the treatments are different. You need to diagnose them in these other two conditions so that if they're not responding, the neurologist will consider doing Plex or upping the treatment, because that's what will save their vision if you get on top of it early. So it's not good enough. In the olden days, we would treat an typical optic neuritis, say, come back in 3 months, we'll know where your vision is. It's not good enough anymore, because at 3 months, we've missed the boat, and the neurologist said, now it's too late to treat with the next level of treatment. The MRIs are different between these two, but that's not something as an ophthalmologist we need to worry about. That's something that the neurologists, they can worry about, that side of things. But I think the one point that Dr. Broadley mentioned previously when I've had this discussion with him that's changed my management, and I hope he will repeat that, is to organize an MRI of the spine at the same time as you order an MRI of the brain if you're thinking atypical cases. It saves them another trip through the machine. So how do I think about these patients? I think if they're high risk, and again, Professor Gordon's already talked about what high risk is: bilateral, severe visual loss, recurrent disease, non-white, and an MRI, especially if they have a long segment. When you look at that segment, these are the ones that are atypical, and these are the high-risk categories. But in my practice, I say treat every optic neuritis as high risk. All patients who have optic neuritis should have MOG and NMO antibodies on initial presentation, because you want that result as you're waiting to see them with steroids. Like Professor Gordon, I tend to offer all patients steroids these days, and I let them make the decision, but because I don't often have the results of the antibody testing, I do tend to offer it a bit more for them. And again, I'll let Professor Broadley talk about whether we should be giving high-dose oral steroids, now that I know our neurologists in New Zealand are doing this a bit more, or whether we stick to the IV, but I'll let him take the responsibility for that one. Okay, I will end it there. Thank you.
Next, we welcome Professor Simon Broadley. And as mentioned previously, he's the expert in neuromyelitis optica and has actually organized the Australia-New Zealand NMO study group. Thank you.
Thank you very much, Celia, and thank you for inviting me to talk. I agree, it's a fantastic forum to have ophthalmologists, neurologists, and others talking together. I always learn so much. So I'm going to talk about NMO and MOG disease from a neurologist perspective. And I'll perhaps beg to differ a little bit about antibody-negative disease. So MS, we've known about for 150 years. We're very comfortable with. We know the pathology. We still don't know exactly what causes it, although we've got a lot of good ideas about what the main factors are. But we have very good treatments for it, and as Andrew pointed out, MS is now a very treatable disease, and we do not see people getting into trouble in the same way we used to, as long as we catch it early. Devick's disease, or now I would refer to it as aquaporin 4 positive NMO. And so when I talk about NMO, I'm talking about antibody-positive disease. Then we have MOG antibody-positive disease. There should be a fourth arm in this little illustration I've given you, which is the other stuff that I don't know what it is. So these are people who have some features of NMO or MOG, but are negative for both the antibodies. If it's just recurrent optic neuritis, we tend to call it CREON, but the others who have a bit of everything, I'm not really sure. They are probably a mixed bag. Some probably have MS, some have probably some other antibody yet to be discovered. Some may genuinely have NMO or MOG, but just happen to be seronegative, but I think it's very hard to pick who those ones are. But it's probably fair to say they probably react in terms of treatment in a more similar way to NMO and MOG disease. Just to highlight a couple of things on this slide. So the picture of the woman at the bottom in the middle is Vanda Lennon, who discovered the aquaporin 4 antibodies. She's actually from Sydney and now works at the Mayo Clinic, has been there a long time. And the woman on the right is Fabienne Brilot-Turville, who is also based in Sydney, who has been very prominent in defining the role of MOG, particularly in pediatric MOG disease, and has got probably one of the best MOG assays in the world. So if you're sending blood off to get tested, if you're sending it to your local lab, they will use the Euroimmune chip, which will actually test for MOG and NMO on the same chip. It's very good. It's particularly good for NMO. It's got almost 100% sensitivity compared with a cell-based assay, such as the Mayo Clinic assay. However, for the MOG one, it has got about a 10% false negative and false positive rate against a cell-based assay such as the one Fabienne does in Sydney. So my advice is always send it to Fabienne. And you can do it through, here in Queensland, we do it through QML Pathology, who will gladly send it off. They charge about $30 for posting it, but I strongly recommend you get that done rather than the local test. So we've already had mention of the pathophysiology of MS, T-cell mediated myelin disease. NMO is a channelopathy, and it's an astrocytopathy, effectively, because of the density of these water channels, aquaporin 4 water channels on astrocytes. MOG disease is an oligodendrocytopathy, so it actually you lose oligodendrocytes very early in MOG disease. So it's also demyelinating, whereas MS, the oligodendrocytes are relatively preserved. MOG disease, you lose them quickly. In terms of the relative frequency, we've known for a little while that NMO is about 1% of what we see in MS. And we've got reasonably good figures for from Australia and New Zealand of a prevalence of around 0.7 per 100,000. Our own studies, which are not yet published, and others around the world, suggest that MOG disease is probably about twice as common in the adult population. So you're more likely to see MOG disease than you are NMO. In terms of the demographics, we've had some references to this already. MS is about 75%, or 3-to-1 female to male ratio. NMO is more like 6-to-1, so about 85% female. MOG disease is getting more towards kind of 50 to 65% female, so much more closer to 50-50. In terms of the age of onset, we've already had mention, MS typically 30 to 40 kind of year age bracket, or actually more like 20 to 40, sorry, with a mean around about 30. Second peak in males in a slightly older age group. NMO's got this much broader distribution, so the tail end, particularly people developing disease after the age of 50, is much more likely to be NMO than it is to be MS. MOG disease has this big peak in the pediatric population with a mean somewhere about 10 to 12 years, and then has a second peak at actually around a very similar point to the peak in MS. But it also has this little bit of a tail, not quite as prominent as NMO, but you certainly see it in the older population as well. Again, we've had several references to the various presentations. One thing I'll flag is that NMO, 75% of people will have a longitudinally extensive spinal cord lesion at some point in their disease, so that's really the hallmark of NMO. The optic neuritis is almost a kind of side story, but the atypical forms of optic neuritis are what you see. For MOG disease, it actually very much depends on how old the patient is. In children, they present with ADEM, which often includes optic neuritis. In young adults, it often presents with simultaneous cord disease and optic neuritis. Fairly typical original simultaneous Devic's disease. So it's speculated that some of the original Devic's cases, particularly the younger ones that were described, actually probably had MOG disease rather than NMO. And then in young adults, you get what I call, it's a bit of a misnomer, but focal encephalitis. So these are people who present with headaches, cognitive impairment, seizures, but actually on their MRI have a focal area of T2 signal change, usually just below the cortex in one region of the brain. So they present with these sort of slightly more global symptoms, but actually have a very focal area of activity. And it's a very unusual particular presentation, which I can recall now having seen probably 4 or 5 times in my MS cohort over the last 20 odd years, who probably actually had MOG disease, but I didn't know it at the time. And then finally in adults, it presents with recurrent optic neuritis. So neurologists like MRI scans. If you see so-called Dawson's fingers, so these projections up from the ventricles on the lateral scans, you can call it MS. You probably do not need to do any other tests. Similarly, if you see juxtacortical lesions or lots of gadolinium enhancement in the brain, then it's probably MS. The short segment spinal cord lesions are typical of MS, but the problem is you also see them in NMO and MOG disease. In NMO, longitudinally extensive cord lesions are the big hallmark, but hypothalamic lesions, area postremal lesions giving rise to the hiccups and persistent vomiting. And then lesions of the chiasm are the other kind of really typical one. MOGAD presents with ADEM, so big blobby lesions throughout the brain and the whole nervous system. These large cerebellar lesions are a feature that's been seen relatively recently, bilateral optic neuritis, and then lesions of the spinal cord, particularly long lesions that go all the way down to the conus, is very strongly suggestive of MOG disease. So this is just some work we did looking at cases of MS, which is the red on the left, NMO purple in the middle, and there's a small group of MOG cases in the green on the right that shows the distribution of the spinal cord lesions. So the yellow indicates a small short segment lesion, the red indicates a long lesion, and the white indicates gadolinium enhancement. So the big thing to note is that gadolinium enhancement is much more common in NMO. So MS, gadolinium enhancement in the brain, NMO, gadolinium enhancement in the cord. And obviously the long lesions are very predominant. Obviously, MOG disease, fewer cases, but you also quite commonly see these long cord lesions. And you'll notice they go all the way down to the conus very frequently. The other thing that's been mentioned we neurologists like to do is look at the CSF. And it's been mentioned about oligoclonal bands. So if you have someone newly diagnosed with MS, oligoclonal bands will be positive in about 50%. Over time, that will become more like 90% if you bother to trouble people with repeated LPs, which you don't generally get a lot of people queuing up for. However, in NMO and MOG disease, it's more like 10 to 30% are still positive. So it's actually not a big difference. So in terms of distinguishing between the two, it is helpful, but it's not definitive either way, obviously, as you can see. However, a more active CSF generally, whether it be an increased CSF protein, which you particularly see in NMO, or a raised white cell count, which you see in both, but particularly prominently in MOG disease. And I think that's because it affects the optic nerve and spinal cord, which in my simple mind just means that the lesions are closer to the surface of the CNS in those two regions, and that's why you're more likely to get cells. In terms of acute treatment, it's been mentioned how MOG disease is much more likely to be very steroid responsive. And that's a kind of, it's been speculated that perhaps the only reason the treatment trial in optic neuritis was successful was because it probably included cases of MOG disease, because they're the ones who you treat and they get better very quickly, whether it's oral or IV. The problem is with someone who's newly presenting is you do not know their antibody results yet. You probably, in my case, probably going to have to wait several days to get an MRI, and yet you're going to have to treat people. So my practice is if it's atypical in any way, and that includes 660 vision or worse, I will treat it as NMO, because NMO is the one that will not recover, and you don't know that at the beginning. So I give, usually depending on how I'm feeling, 5 to 7 days of IV methylprednisolone. I will start oral steroids straight away afterwards, and I will start Plex right at the beginning. Wow. So we call our hematologists in to come and do the Plex for us over the weekend, if there's anything atypical about it, because 2 weeks down the track is too late to start the treatment. You have to clear the antibodies immediately. And for NMO, Plex is probably the only thing that works. Whether steroids work in MS is very debatable, definitely works in MOG disease. Once you've used your acute treatment, then you need to make a decision about what to use next. In MS, Andrew's already alluded to, we clearly know what to use, but for NMO, things were not so clear for a long time, and people use kind of standard immunosuppression approaches. And there's lots of studies looking at this now. This is not probably the best data, but it happens to be Australian, New Zealand data, and this is our comparison of rituximab against standard kind of immunosuppression, a few cases of beta interferon, because they happen to be in there, and no treatment at all. So no treatment is the green line down at the bottom, probably not a good idea. Whether immunosuppression is any better is a bit debatable. That's a bit difficult because this was kind of any regime of immunosuppression. If you're going to use immunosuppression, you have to suppress to get lymphocyte counts down to around 0.5. If you're not doing that, you may as well not bother. But that obviously comes with lots of risks long term. Rituximab has been shown in repeated studies now to be the preferred option. It is almost certainly the safest, and it is the most effective. But there have now been 3 phase 3 clinical trial programs looking at different agents in NMO, and I'll just flag the Guthrie-Jackson Foundation. So Victoria Jackson was a makeup artist to the stars in Hollywood, whose daughter got NMO, and she set up this foundation, and they've generated huge amounts of money. They have Dustin Hoffman on their promotional videos, and they have really invested their funds very wisely and managed to work with the FDA and the various pharmaceutical companies to get these trials up and running for what is a pretty rare disease, which is quite a major achievement. So these all finished about 3 or 4 years ago. Inebilizumab is just another CD19, CD20 agent, so it's a B-cell depleter. It certainly confirms that B-cell therapies work. Satralizumab is an anti-IL-6 receptor antibody, so this kind of modulates your immune system from towards a less reactive phenotype, and it certainly also works and is possibly a little bit more effective. But finally, down the bottom, eculizumab, which is an anti-complement 5 antibody, is the most effective. It pretty much stops all attacks. So in practice, we find rituximab works really well in about 3/4 of people. There's a final quarter in whom that won't be enough, and so we need to look at these other agents. Rituximab has just been made available.
Can we get you to?
Yep, sure. Rituximab has just been made available on the PBS for kind of any autoimmune disease, so we now have access to that. We don't have satralizumab, and there's no plans to go to either TGA or PBS for it, but we do have access to tocilizumab, which is a very similar drug, and people have been using that through a local IPA. Unfortunately, 2 submissions to the PBS to get eculizumab approved have failed, and they're probably not going to try again. It's all about the cost. It's about $100,000 per year. So it's only approved for HUS at the moment. Eculizumab has one big drawback, which is the risk of meningococcal disease. And even if you are vaccinated, the vaccinations only cover the 3 commonest serotypes. And unfortunately, there are several other serotypes which are not normally pathogenic, but if you're on eculizumab, you're very susceptible to it, and they are out there in the general population. So unfortunately, the rate on eculizumab is still 1 to 2 per 1,000 per year. So over 10, 20 years, the risk becomes quite substantial. So some people are now just giving routine antibiotics. MOGAD, we basically don't know. So I was part of a working party that came up with these international opinion guidelines. And first line, it's recommended to use immunosuppression. I have to say, for safety reasons, I've largely translated to just using rituximab. In pediatrics, they use IVIG quite a lot, and it's probably a fairly safe option. I'd just like to thank all of these people who've been involved in the various bits of research that we've done, particularly in the NMO space, but increasingly now also in MOG disease through Darshi Ramanathan, who's also based in Sydney. Thank you very much.
Thank you, Simon. Thank you. In the interest of time, we'll move on to our giant cell arteritis topic, and we will aim to, at the end of it, also answer some of the questions that were raised at the end of the session. Thank you. Next, it's my pleasure to welcome Dr. Janne Andersen, and he's going to present to us the ophthalmology perspective of giant cell arteritis. Thank you.
Good afternoon, and thanks very much to Helen, Celia and Claire for arranging the conference session. So giant cell arteritis, a lot of textbooks make it sound very, very simple to diagnose and manage this condition. It's not quite as simple as that. So we'll just go through this about the important points from an ophthalmology perspective. Firstly, it is challenging to diagnose. It requires a low index of clinical suspicion, and the reason why that is the case is because of its potential to cause profound and permanent vision loss rapidly. And also it has potential for mortality, and that's more and more recognised as a result of large vessel disease. Investigations are helpful, but they should not delay management. So if you're considering giant cell arteritis, it's really important to start the treatment as soon as possible. You need to start steroid treatment. That is the thing that works quickly, and it needs to be instituted urgently. And you have to remember that these sort of managements have potential side effects, particularly in the demographic of people that you're treating, which are generally elderly with other comorbidities. And management after the initial urgent institution of steroids really does require the input of a physician, preferably someone who's got rheumatology or immunology expertise, and that's where David's going to come in because he's the brains of this show, not me. Now, the history of giant cell arteritis has a few devastating stories, and I think all of us as neuro-ophthalmologists all have our giant cell arteritis, oh my goodness me, what happened here story. And it still occurs today, some flawed clinical reasoning. You witness it and you think, oh, I thought it was giant cell arteritis, but I decided to wait for the temporal artery biopsy. It's come back negative, but they've lost vision in the second eye, so what should I do, sort of story. And that still is occurring. And so just an example, this is a case that I saw a few years ago. So 72-year-old male, transient painless monocular visual loss, so amaurosis fugax, and treated by a physiotherapist for 2 weeks with new onset neck and scalp pain. First presentation to an emergency department in a tertiary teaching hospital in the ophthalmology department. Normal examination, suspected giant cell arteritis based on the history, liaised with someone with senior training who thought it was embolic but did not see the patient, and arranged a vascular workup as an outpatient. A week later presents with a central retinal artery occlusion, and because of groupthink, just thought, oh well, it's now become worse, so we better get this vascular workup expedited without actually thinking about a potential differential diagnosis. And then presented 24 hours later with no perception of light bilaterally, swollen pale discs. I mean, which, you know, you look back and you think, holy dooly, what were you not thinking about here? So commenced treatment, and this patient is memorable for me because this patient thanked us for treating them because they felt so much better, even though they were completely blind. Died from an intestinal infarction, family were devastated, hospital successfully investigated and successfully sued. So, you know, this condition has really bad outcomes if you leave it, and it's treatable and it's recognisable. So in terms of what the disease is, it's a medium to large vessel vasculitis. It's relatively uncommon, but it's one of the most common vasculitides and certainly the most common large vessel vasculitis. It generally occurs in people above 50 and generally older than that. It's got a female preponderance and it's mainly in Caucasians. And it has varying phenotypes, so cranial, which is the one that the ophthalmologists tend to see, large vessel disease, which can be seen by vascular surgeons, and other physicians and other surgical specialties, particularly if there's infarction going on in organs such as the bowel. And then polymyalgia rheumatica. And there are no definitive signs or symptoms of diagnosing giant cell arteritis. It's actually a constellation of findings and you just need to be suspicious of it. It has to enter your mind when you're looking at these potential things. And so you need to take a thorough history and take some time in your examination to really make sure you can exclude the diagnosis. It's that way of thinking that's important. It's not about it may be giant cell and include it in the differential. Is have I effectively excluded giant cell arteritis from this diagnosis, this patient's diagnosis? Systemically, these include new onset headaches. So these are people who might have headaches in the past, but they say these are different. These are new headaches to me. You know, they're a different nature. They're not in the back of my head like all the other ones are. They're not one-sided like all the other ones are. Jaw claudication, which is the onset of pain after prolonged chewing in the jaw or in the tongue, and it's a predictor for permanent visual loss. So it's an important symptom to recognise and ask about, and if they've got it, really be suspicious. Scalp and temporal artery tenderness, and then constitutional symptoms. So this is the polymyalgia sort of spectrum of conditions, of symptoms. And then polymyalgia, 50% of giant cell cases have polymyalgia, so that's the upper limb girdle pain. And giant cell arteritis develops in 10 to 30% of polymyalgia cases. So there's this crossover or this spectrum. So if they've got polymyalgia and they're presenting with a new onset headache, you have to be very suspicious of giant cell arteritis. Ophthalmic manifestations, vision loss, temporary or permanent, amaurosis fugax, which is the transient monocular visual loss or binocular. It's a predictor of permanent visual loss, so once again, really be important. Arteritic anterior ischemic optic neuropathy, choroidal ischemia, central retinal artery occlusions, ciliary retinal artery occlusions. Branch retinal artery occlusions, I think, are very rare in my experience. posterior ischemic optic neuropathies, I think, are also one difficult to diagnose but rare. Double vision, it does happen. You see a few cases, but it's less common than the vision loss, and it's due to ischemia at all levels of the efferent pathway, so brain, stem, nerve, and probably some vascular impairment of muscles. And then pupil disturbances are reported but rare. So diffuse pallor of the optic nerve with arteritic anterior ischemic optic neuropathy and cilioretinal artery occlusions, and the combination of both of those two, if you see it, that's pathognomic almost. So large vessel disease, that's aortic murmurs, limb claudication, peripheral arterial bruits, particularly axillary bruits, and this is the EULAR, which is this European League Against Rheumatism. This is their sort of breakdown of what you should be looking for. It really slightly repeats what I've been saying, but it's a good way of sort of tabulating it from my perspective. The American Rheumatology Association's just released some of their findings as well, and they're similar, but I have to say most of their comments or changes to their protocols were not based on really strong evidence, and they acknowledge that. So basically these are the things that I'd use in my diagnostic tree. So you try and organise haematological investigations urgently, but if you've thought it's giant cell, don't even bother waiting, just get the treatment going. The sensitivities vary a little bit in the literature, but if you use a CRP and an ESR together, it's very sensitive. High platelet count, anemia of chronic disease, you can get disrupted LFTs. And a couple of other things that are quite useful, but the trouble with these two tests, the plasma viscosity and the acute serum amyloid A, is they often take a bit of time to get. Temporal artery biopsy is now not necessary in certain circumstances for the diagnosis of giant cell arteritis, so that's a bit of a change in the paradigm. So if you think the diagnosis is barn door obvious and it's not going to change your decision to treat, you don't really need to proceed to biopsy, in my opinion. And that's sort of pretty much a recommendation, not just some anecdotal opinion. And also, if you can confirm it by cranial vascular ultrasound. Now, the thing about vascular ultrasound is you really need good sonographers. I'm quite fortunate in that the two vascular surgeons I work with up on the Sunshine Coast have their own ultrasound laboratory. So these people are really on to recognising, or very good at vascular ultrasound, cranial vascular ultrasound, but they also know the story about large vessel giant cell arteritis. So you basically send them and say, can you get a temporal artery biopsy done? And what they're doing is they're doing this and they're doing the ultrasound scans on the big vessels as well. So these guys know what they're talking about. And, you know, that helps, but not everyone has access to those facilities. Don't delay treatment if you're planning to do a temporal artery biopsy. So it sort of makes me sort of quite nervous when I'm sent someone along. I think it's giant cell arteritis, but I'm just waiting the temporal artery biopsy before I start the treatment. That's just really not good thinking. It's flawed. If you think it's giant cell, treat it. The yield remains pretty good at least 2 weeks, probably even longer after commencing steroid therapy. I generally use unilateral biopsies. I don't tend to do bilateral. There is a slight discordance rate. Interesting figures though about sensitivity and specificity. They're not 100%. And it's a relatively safe procedure with a low rate of adverse outcomes. Nowadays, I tend to let the vascular surgeons do this, so it won't be too long, Celia. So just a couple of things for trainees and stuff. Large specimen, so 4 centimetres is what you should take. I don't use adrenaline. I tie off the vessels and close in layers. These are elderly people who are going to be on steroids, so really make sure your closure is good. Ultrasound guidance is good. And if you're struggling to find it in the operating theatre and you've got anaesthetic cover with you, ask them to give them some IV aramine, and that can increase the pulse pressures so you can find it. I just might whiz through this because we're just on a time limit. The one thing I wanted to say there is this last one. And in the giant cell arteritis studies, this was the case that there is a considerable variation in interpretation amongst pathologists with regards to temporal artery biopsies. So it's important to note that you might get a negative report, but it still may be giant cell arteritis. So if you think you're clinically suspicious, keep going with your treatment. So in summary, it's important diagnosis not to miss from an ophthalmologist's point of view. The diagnosis is not as easy as what you read in the textbook. Low threshold to investigate and treat, and temporal artery biopsy is not always the gold standard now. And it's always wise to involve a physician in this because both the disease and the treatment have considerable morbidity and potential mortality. Thanks for that.
Thank you, Yanni. And now we are very privileged to have an immunologist, Dr. Hayward Smith. And this is where what happens after we've diagnosed giant cell arteritis. Do we co-manage? And I would love to hear more about tocilizumab. So thank you, David.
Thank you very much. I thank the chairs, and I'm very grateful to follow Yanni with this talk. So I'm going to approach this from an immunology perspective, a bit more about longer-term treatment and management. Sorry, is it this one? It's the big green arrow. I'm a clinical immunologist at Greensleeves Private Hospital. I have no conflicts of interest. So from an immunology perspective, we sort of see two kinds of presentations. There's the sort of, if you like, the more classic sort of cranial presentation that Yanni's described, with the patient presenting with headache, maybe ocular symptoms, maybe some polymyalgia, high inflammatory markers, and a positive temporal artery biopsy. And so then when I get that diagnosis, that patient with a nice diagnosis handed to me, my next job is to work out, do they also have extracranial disease, large vessel disease? Then the second presentation that I see is sort of the inverse, where we have a patient who has more diffuse constitutional symptoms without localizing symptoms of a very sort of inflammatory situation. And often they're worked up in a non-specific way with cross-sectional imaging, looking for lymphoma or infection or something or other, and that demonstrates large vessel vasculitis. And so then we go back and look at the patient and send them to ophthalmology and go, well, have they got eye disease? Do they need a temporal artery biopsy, which they almost certainly do. So the initial clinical sort of considerations for these patients is, firstly, is it GCA? It's often a fairly watertight diagnosis, but there are differentials. What's the acuity? Is there sight-threatening, organ-threatening, life-threatening disease? Is there extracephalic disease? And then also, we need to get on with treatment, but also what baseline data do we need about the patient so we can make judgment about the success of treatment and also craft our treatment so we don't cause the patient too much morbidity. Most importantly, and we've talked about it a bit already from the other speakers, what will be the tolerance of long-term corticosteroid therapy over a year or more? What disease-modifying therapies can we use? And for this patient, with that treatment, with their presentation, what kind of morbidity and mortality might they expect, and how can we try and improve that? Just briefly in terms of pathogenesis, just two things I want to mention. Firstly, it is a medial disease with granulomatous inflammation, and you get apparently activation of the dendritic cells, the antigen-presenting cells in the vasa vasorum as a kind of early event, and that recruits a lot of other inflammatory cells, including T cells and macrophages, leading to giant cell formation and inflammation. And the second sort of really key thing is that a lot of the cells, all of the immune cells, but also the smooth muscle cells release interleukin-6, which is a really key mediator in this disease, and it provides us with a target for treatment, which we'll hear about tocilizumab. And also, as we know, CRP levels basically are driven by interleukin-6, and that's why CRP is a good diagnostic and index test. So is there a differential diagnosis? Well, there are other vasculitic processes that can cause vasculitis in the temporal arteries. That can include ANCA-associated vasculitis, PAN, IgG4-related disease, and varicella. And then there are other systemic inflammatory disorders that can kind of present with a polymyalgic, inflammatory, non-specific kind of syndrome, including sarcoid, again, IgG4-related disease, the cognate autoimmune diseases like lupus, adult onset Still's disease, lymphoma, and infections. So we just have to always have a bit of an index of suspicion, because there's often a very nice narrative that it's GCA, but we don't want to get misled by framework bias and miss something else important. So in terms of the diagnostic activities, we've heard about the lab markers, the TA biopsy, Yanni's elegantly discussed, temporal artery ultrasound scan. So I'm going to talk a bit more about cross-sectional imaging, looking at the large blood vessels, and CT, MR, and PET is what we can use. So I won't talk too much more about temporal artery ultrasound. Yanni's pointed out that you do need local expertise for that technique. And in an Australian study, I think it was actually out of Canberra, they had like 90% sensitivity and specificity. So obviously very good hands there. International studies, more like about 60 to 70%. And then in terms of cross-sectional imaging, we've got contrast-enhanced CT, PET, and MRI. Now with the cross-sectional imaging, one of the things that we find can be a problem diagnostically is some of these patients are elderly and they have atheroma. That can be inflammatory, and it can be inflammatory in the PET, and you can have FDG uptake. So that's just one little thing we have to look out for. This is a temporal artery ultrasound showing the typical halo sign with a hypoechoic lesion that surrounds the blood vessel due to edema. And looking at some PET scans now and MR. So in this patient, we can see very nice green FDG avidity in the aorta. And there's the same patient, and you can see with the arrow on the aorta, there was like mural thickening and GAD enhancement. This is another patient with a bit more florid disease, and again you can see extensive, almost pan-aortic FDG uptake, both in the 3D reconstruction and also in the cross-section. This is another patient who was suspected to have GCA and went on to have a PET. As you can see in the aortic and large vessel area, in fact, there was no FDG uptake, and they had silent diverticulitis. So that's another reason why this can be helpful as a tool in differential diagnosis. So what about treatment options? Well, corticosteroids, and then we have second-line agents or additive agents, so we're going to use methotrexate and tocilizumab. And then we need to think about platelet inhibition. Salvage therapy is probably with cyclophosphamide if patients are failing on the above. I won't talk about that too much. And then there are a number of investigational agents which haven't really seen too much use, like the JAK inhibitors. I think for me this is the most important slide. So what are the considerations for the patient in terms of their tolerance of treatment and treatment selection? So really it relates to their age and their pre-existing conditions, because as I mentioned, these patients will be on prednisone for at least a year, if not longer, starting at a pretty high dose and then tapering down. So things we need to know about is diabetes, osteoporosis, age-related sarcopenia. If I give a patient with who's frail, high-dose steroids, that might mean that that patient gets a proximal myopathy and then they can't live at home anymore and need to go into care. Mental health disorders can be exacerbated by high-dose steroids. And then ocular complications, of course, glaucoma, cataracts, central serous retinopathy can occur. Do they have a chronic infection that's going to be released by immunosuppression? Chronic kidney disease, if they've got end-stage renal failure, we give them high-dose steroids, then we'll put them onto dialysis. And have they got other infections or cardiac disease? So fortunately, we have really concise and clear and current treatment guidelines from the American College of Rheumatology, which I think is pretty authoritative in this space. So essentially, if there is any organ, site or life-threatening disease, we should use intravenous steroids with pulse methylprednisolone. If there is disease which is not immediately site-threatening, or not organ or life-threatening, then we can start with high-dose oral steroids, about 1 milligram per kilogram per day. And that applies to both essentially cranial and extracranial disease. And then with all of the presentations, we should think about disease-modifying therapy, which will enable us to taper the steroids in a faster way without encountering relapse. And we really have two options nowadays that we would use, although there are others, but mostly methotrexate, and that's good because it's unrestricted on the PBS and we have a lot of experience with it, and it's generally speaking a safe agent. And the second is tocilizumab, which is a potent agent in this condition. It's got good data, but and it's mostly safe, but there are some restrictions on the PBS because of its cost in terms of severity criteria. If there is ischemic disease, we should use antiplatelet agents as well. If a patient has acute limb ischemia, then we need to juggle intensifying immunosuppression, again usually with high-dose intravenous steroids, and also instrumentation either surgically or through angioplasty. And what we can do there depends very much on local expertise and what's available. So just going through those treatment options in a little bit more detail, the corticosteroids, as mentioned, is going to be prednisolone, 1 milligram per kilogram per day, and usually slowly tapered, so we might drop off by about 10 milligrams per month until we get down to around about, say, 20 milligrams, and then we taper more slowly and come off that over about another 6 months or so. And we need to be aware of those corticosteroid complications. Methotrexate is routinely used. We have good experience with it. There's not very good data from studies, but both anecdotally and from the small studies that there are, it does seem to reduce the risk of relapse as we taper the steroids, and maybe let's just taper them a little bit more quickly. And then with tocilizumab, which is an interleukin-6 inhibitor, we've got well-designed RCTs showing that there's a significant reduction in relapse during steroid tapering. So that's good, we can use that. Now, just briefly with tocilizumab, as I mentioned, there are some restrictions on it through the PBS. Firstly, treatment has to be initiated by immunologist, rheumatologist or neurologist, and you need to have a defined clinical syndrome. You need to have high inflammatory markers at the time of diagnosis. You need to have either a positive temporal artery biopsy, or you need to have positive cross-sectional imaging showing large vessel vasculitis. And you need to do the treatment in conjunction with a tapering course of steroids, which you generally would anyway, and you only get one crack at it in your lifetime. So the PBS only supports 52 weeks of therapy in one lifetime. And then finally, in terms of the prognosis of this disease, it does have significant impacts on morbidity and I think mortality. However, studies across time have shown that with our novel therapies, we're getting better survival. Interestingly, a fairly recent Australian study showed no effect on survival versus age-matched controls. I found that a bit counterintuitive, and larger international studies show that there is an impact. And so in the sort of larger study that was in Scandinavia, there was about a 4-year earlier death survival was for 4 years versus 8 years for age-matched controls. So I think it really can affect patients significantly, and we know that there's significant morbidity in terms of infections and metabolic problems from the treatment that we use. That's all I wanted to say today. Thank you very much.
Yeah.
Thank you very much. I've just got one quick question for you both. Do you think that in this era of ultrasound and PET scan imaging that there is such a thing as just clinical giant cell arteritis, or would we always have to find either something on biopsy or one of those vascular imaging sessions now to be able to make a diagnosis?
I think that there probably is a clinico-radiological diagnosis with laboratory markers, and you don't always need a temporal artery biopsy, particularly in patients that present with large vessel disease. But having said that, sometimes the diagnosis and the presentation is a little bit untidy, and then we're a little bit down the track with steroids after 2 or 3 months, and we don't know what we're doing, and the patient's not getting better, and we really wish we'd done the temporal artery biopsy at the beginning so we had a watertight diagnosis.
Thank you.
Yeah, I agree.
Lovely. Thank you both so much. I'm sorry we only have time for one question for you both. Thank you. All right, it's my great pleasure to now introduce my co-chair, Professor Celia Chen, who's going to talk to us about central retinal artery occlusions from the ophthalmic perspective.
Okay. Good afternoon, everybody. Now, I'm going to talk about central retinal artery occlusion, and it's when you get that acute blockage to that main supply to the eye. I once gave a talk called White is Bad, because it's either infection or infarction. And in this case, because of that blockage, that infarction, you can really compare to the other side and appreciate that paleness because of the infarcted retina, and that's why we got a cherry red spot. But look at that artery, how thready it is. Now, we've heard about giant cell arteritis. Now, in this talk, I'm going to concentrate and set the scene that I'm talking about the thromboembolic causes of central retinal artery occlusion, which accounts for 75 to 80%. Now, in the thromboembolic CRAO, this fluorescein angiogram is quite illustrative because people keep talking about you see a visible emboli in only 20% of cases. But remember, there's that thrombus, that very thready artery. So that's why your fluorescein has got that box-carring appearance. Now, what happens to them? They present with poor vision, and they end up with poor vision. And I do have people say, so what? I've got the other eye. No, not really. Okay. I mentioned about testing your stereopsis coming down these steps. The reason is because unilateral loss of vision, the biggest risk is dependency. And also, if one artery is blocked, you are more at risk of another ischemic end organ damage. And that is why these people have a very high incidence of ischemic heart disease and cerebrovascular accident. And this is where our stroke neurologists will be coming in. Now, as a neuro-ophthalmologist, when I see a patient, I think, what is the problem? Where is the problem? And now what? Okay, so this is now the fun bit. The management of acute central retinal artery occlusion, there are three. The first is, can we reperfuse that vessel? Can we unblock it? Secondly, don't forget that sometimes the artery occlusion can actually cause secondary complication. And thirdly, very importantly, as I said, these people may be at risk of another end organ ischemia, so it's important with secondary prevention to prevent further damage. And we're going to hear the neurology perspective. The acute management for reperfusion, really, there are two big categories, non-thrombolysis or thrombolysis. And in non-thrombolysis, some people say they observe or admire the disease, as Helen says, but we may be looking at that very lucky 1 to 5% who have transient CRAO. Not everybody can buy a cross lotto. Sometimes people try various ways to dilate the retinal artery. The way I think of it is, remember that fluorescein angiogram, how that very thready vessel is? It reminds me of this picture of the biggest traffic jam that spanned over 300 kilometers. Just by opening one more lane, it's not going to decongest that, unfortunately. And sometimes people try to dislodge it. Now, I used to put invasive versus non-invasive, but I found that sometimes when you don't have a good method, people can go into quite drastic measures to use vitrectomy to try to dislodge your emboli. I wouldn't recommend that. And because your perfusion pressure is the difference between your mean arterial pressure and your intraocular pressure, there are various ways people try to deflate the balloon to increase that perfusion pressure, and various combinations. Unfortunately, we've looked at the comparison over time, and generally in America, people do try more methods compared to in Australia, but guess what? Results are very similar. So the tide has come, the tide has gone, and we still haven't got the answer. Now, this is where the stroke neurologists in the audience are getting excited, because we are borrowing from them. This whole idea about reperfusion has actually been around from the heart people and the stroke people. We've got thrombolytic agents. Can we unblock it? Can we lyse the clot? And this is work that I started when I was a fellow overseas, and at that time they were using intra-arterial, parking a catheter right at the origin of the ophthalmic artery and squirting aliquots of TPA. And it does work, but this is where the but comes in. The intra-arterial pressure, you really need the right expertise. And I still have sometimes people emailing me and saying, my radiologist is very keen with this, and I'm very happy to share the protocols. But again, it is coming down to institution, the right people. And you'll hear me say that a lot. In Australia, we actually did the first randomized control trial for intravenous TPA in central retinal artery occlusion. It's a collaboration between multiple centers, including Claire here. And we found that the only people who improve are the people who are treated within 6-hour window. Every time I present these, people quote Hey Ray, saying, but I thought it's 97 minutes. Now, what happens is that 97 minutes give you complete recovery, but you can get partial recovery up to 240 minutes in his monkey model. And it's very interesting with these 240 minutes, because more recently in 2020, with collaboration with the US, we found out that the 4.5-hour seems to be the window. And again, we're tagging on to the stroke thrombolysis protocol, where they started with 3 hours, they extended safely to 4.5. And 4.5 does seem to be that magic number where the vision may be salvageable. Okay, and so thrombolysis in CRAO, watch this space because it's, there's definitely a lot happening. People used to say neuro-ophthalmology is like buying the right house. Location, location, location. I think it's the right marriage. You need the right person at the right time in the right place. Okay. Now, the treatment of local complications. The eye is a very interesting organ. My stroke neurologist husband says, gosh, I wish the brain would reproduce some vessels because the eye is one organ that neovascularizes. But we don't like that. So when there's ischemia, the eye tries to be clever to produce new vessel, but they are flimsy vessels and they bleed. Everyone think about vein occlusion causing that neovascularization. Guess what? It happens in artery occlusion, and as much as 18%, and the average time is between 8 weeks to 4 months. And so don't just think, yep, you got CRAO, see you later. Watch for that local complication and treat it if you have to. And last but not least is management of systemic vascular risk factors. Okay. Now, again, this is important because we found out that 2 out of 3 people actually have undiagnosed vascular risk factors. It's not quite enough, as we heard from Deborah's talk, to say, are you well? Okay. When they say, no, I don't have diabetes, I ask, when was the last time you had a fasting blood test? You'll be amazed, okay? Or someone will be denying everything and the wife is there nodding their head, okay? Now, everybody have their recipe, and this is my recipe for the systemic workup, and this is where I always get asked the question, do we do it? Do we send them to the GP? Do we send them to the neurologist? Now remember that nice marriage, right person, right place, right time. You look at the system that works for you. If you're in a teaching hospital where they've got the TIA rapid assessment clinic, that would be the perfect place. If you're in a country where you've got good working relationship with your GP, then that would be the person. So again, find the system that works for you. And this is probably a very nice lead up to now introduce my, co-neurologist person to talk about the systemic management for secondary complication of central retinal artery occlusion. Thank you.
Thanks very much, Celia. Fantastic segue into my talk as planned. And thank you for the invitation to speak. It's great to be here in person. Thank you all for travelling to Brisbane to come and see me talk about this. Very kind of you. So I'm going to try to get through this relatively quickly, but without shortcutting or shortchanging any of you. I've got a lot of disclosures. I won't read them all out. I prefer to think that I'm biased in every direction and therefore not biased in any direction. I can't recommend this as a career plan, though, for those who are thinking about that. So when someone's referred to me with a central artery, certain retinal arterial occlusion, what are my goals? Well, we've just heard a great talk about what we can do to salvage the acute situation, so I'm not going to go into that in detail. I will say that thrombolysis should work, and although we get clear suggestion that in the first 4.5 hours that's the right thing to do, it really should work because of the timing. We know how robust the retina is to ischemia. We know that large vessel occlusion, by which I mean an internal carotid artery or a middle cerebral artery, probably is not going to recanalise with thrombolysis. But the calibre of the vessels in the eye are smaller, and theoretically they really should open with thrombolysis, so that should work. And it should be pretty safe, especially if there's no associated infarction anywhere else in the head. Remembering that the clot has lodged near the eye, but doesn't mean that there haven't been other clots lodging further north in the brain. And I would say that we really should be doing a CT angiogram and a perfusion scan of the brain before we start progressing down the acute therapies. Why is that? Because there have been studies looking at what else happens in the head when people have a clot in their eyeball, and you can see in the right-hand column there, the ischemic stroke detection rate can be as high as 75% in someone who initially may only look like they've got a clot in their eye. So it's definitely worth looking further. This is not the case of a patient who had a CRAO, but it is a case of someone who came and saw me and said they had transient symptoms, had no problems left. Thanks very much. Can I get back to work? 47-year-old, runs a store, just had a headache and some transient memory symptoms. He said it was fine. I said, we better do an MRI scan anyway, and this is what I found. A big chunk of brain had been infarcted here, and he needed occupational therapy, several weeks off work and rehabilitation. So just because the patient has an obvious problem in their eye doesn't mean they haven't got a subtle problem somewhere else, and I'll keep looking. What else can we do for prevention? We've talked about the recipe that Celia uses. We have to manage all of these things, and a lot of it does come down to the GPs. A lot of it comes down to the stroke neurologists and the TIA clinics, but there's definitely some aspects of that management which I'm always going to give back to the general practitioner, because I'm going to see these patients for a couple of times, there's a couple of visits in their clinic, but I'm not going to be seeing them throughout the rest of their life. And so these, which I won't go through, are well evidenced and well known to the GPs, and at the end of the day they're much better at managing these risk factors than I'll ever be. There's been a few changes in the way we manage secondary prevention of CRAO as a ischemic event in the eye. One being the use of dual antiplatelets with clopidogrel and aspirin, something we've borrowed from the cardiologists. Then I won't go through that slide in a lot of detail, but just to say that you may see patients discharged from hospital after being referred there with CRAO on dual antiplatelets. Only for about 3 weeks though, and so on the left there is a graph showing the benefit of timing of carotid endarterectomy, and on the top you can see that in the first couple of weeks there's clear benefit from a couple of trials on a meta-analysis in the Diamond, clear benefit to the right of that line of unity of doing endarterectomy in the first 2 weeks. 2 to 4 weeks, you're starting to see a bit of shift towards no benefit. 4 to 12 weeks, the point estimate's still kind of favouring endarterectomy, but past 12 weeks, there's just really not much to gain. And that's the idea of the artery, the carotid artery, being hot when it's a ruptured atherosclerotic plaque. We've got to get act quickly. On the right there is a secondary analysis of the paper I showed in the previous slide, also showing in the black lines the event rate just plummeting in the first 2 or 3 weeks. And after the first 2 or 3 weeks, there really isn't much happening in either the control or intervention arm. Not a lot to do after the first 2 or 3 weeks, but it does mean we've got to get in fast, which means that within the first day on the left side of this table, within that first day or so, certainly with a minor stroke, but we're not too worried about causing bleeding in the head, we're going to be using aspirin plus clopidogrel, then moving on as time goes on to single antiplatelets. We still use anticoagulation for atrial fibrillation, so if someone has AF and for some reason not anticoagulated and they come in with a CRAO, if I can't find any stroke anywhere else, I'll anticoagulate them on day one and then keep looking for other things to treat according to whatever the patient-related factors are. If any of you who have ever seen the use of astaxanthin in the past, you won't see it anymore because nobody can get it anymore. The manufacturers just aren't making it anymore. On the flip side though, clopidogrel has become a whole lot easier to prescribe because it used to have this streamlined authority to prescribe, which is no longer the case. So you might see a bit more of clopidogrel being used. I haven't really changed my advice to GPs about blood pressure and lipid management recently. I guess the target's a bit more clear, with systolic blood pressure of 140, maybe 130 if you can get to it, and a bunch of studies which I'll summarise in one sentence by saying that LDL target's 1.8 millimoles per litre. You might see patients being looked at, for mine, if you've had an embolism to the retinal artery, you've basically had a stroke in terms of secondary prevention. So I'm going to give exactly the same things as I would do if that person came in with a hemiparesis, for example. And some of these people are going to end up with an implantable loop recorder, and that's because at the moment we do have solid evidence for treating AF with anticoagulation, but we don't have very good evidence for just treating with anticoagulation in people who haven't clearly got AF. So we do have these implantable loop recorders, a couple of centimetres long and about that wide, small devices that can just be placed under the skin and the front of the chest there and can find atrial fibrillation for several years. The batteries last for at least 3 years. Then we're on solid ground and we know we can anticoagulate when we find that. And 12% or so at 12 months, up to a third at 3 or so years. So it's really something you'll see more of as more of us start implanting these devices. We also have percutaneously deployed devices that can treat patients who have, well, in the left-hand side, a patent foramen ovale with much better evidence for which patient should have this device deployed. And on the right-hand side, left atrial appendage occlusion devices for patients with AF who have a reason not to be anticoagulated. So, for example, hemorrhage. And my last slide, what are the options for emergency evaluation if someone has CRAO? Well, as we've heard, if you know your local system and you know how to access your TIA hot clinic and you know they're going to get in sometime very soon, that's a great idea. It might just be straightforward enough to send that patient to emergency and let them do the direction just in case the TIA clinic is closed for the week or whatever because someone's on leave. You could just ring the stroke registrar, or bearing in mind that some hospitals don't have a stroke registrar, so the medical registrar who deals with stroke, and they'll probably also help work out where to go. GP is a bit risky to refer to because most of them, my patients can't get in to see the GP this week, so it's not a good timeline. As I said, TIA clinic's great, but only if you know the patient can get in quite quickly, and some hospitals only run TIA clinics on every week, so if it's on a Wednesday, there's no point referring on a Thursday because it'll take them half a week to get in. And then don't refer to a private practice neurologist because I've got the same problem that Andrew Lee has, which is that they'll be waiting for a year to see me and it'll never happen. So please don't refer to you privately because I'm just going to turn it around to the TIA clinic anyway. Thanks very much.
Okay, Andrew, do you want to join us here at the panel? And we've got 3 questions that came through Q&A, and the first 2 I can probably answer, and the third one I'll defer to you. The first question is, do I use hyperbaric oxygen? My answer is no. It comes under that category where you're trying to dilate the vessel. Remember, as I say, it's about right place and right person, and also the setup you have. So for me, it's easier to call my neurologist rather than getting hyperbaric oxygen. So, and also, as we said, they don't seem to work. The second question is, what's the theory of thrombolysis if you have a calcified or cholesterol emboli? Now, very good question, but remember, as we said, you see a visible emboli only in 20% of cases if you look for it. And just like in that fluorescing angiogram, when you have it's what we call thromboembolus. So just because you got a embolus there, you can still have that cholesterol buildup and the thrombus around it, and that's where the TPA or the connect plates are trying to lyse that. Is that correct?
Yeah, that's exactly the same reason why we thrombolyse people with a bit of carotid plaque that goes to the brain.
Yeah. And following on with that question is about the risk of intracerebral hemorrhage. And this is where we need the stroke neurologist because there is a set protocol for thrombolysis. They need a CT scan before they even pass, for instance, because you do need to choose your patient.
Yeah, we know from the cardiac knowledge that if someone does not have an acute pathology in their brain, even with intravenous heparin and thrombolysis and antiplatelet usage, all given at the same time, the risk of bleeding in the head is incredibly low. But that's why we need to scan the head before we proceed.
Thank you.
All right, we'd like to thank all of our speakers today for a fabulous session. I know there are a few extra questions that we didn't have time for, so please feel free to ambush them at the afternoon tea. Thank you, everybody.